Cancer screening and treatment, what you should know and when you should get it. Tonight, On Call with the Prairie Doc. Good evening and welcome to On Call with the Prairie Doc. The battle against cancer has been going on since the beginning of medicine. We've made remarkable progress, but there is still a long ways to go and many questions to be answered. But first, speaking of questions, let's take a look at this week's Prairie Doc quiz question. True or false? The American College of OB/GYN recommends yearly mammograms beginning at 40. However, the American Academy of Family Physicians recommends that annual mammograms start at 50. True or false? Viewers who call in the correct answer will be entered into a drawing to win a signed copy of The Picture of Health. Each of my essays originally written for this show comes with a wonderful accompanying photograph by Dr. Judith Peterson. We'll announce the answer and the winner at the end of the show. Remember, you only have 10 minutes to get your answer in. But we answer your medical questions all night about cancer detection, treatment, as they are called in or sent to us via Facebook or email. So call in your questions to 1-888-376-6225 or send us an email to the address on the screen. Joining us via Skype from Sioux Falls tonight is Dr. Mark Huber with Avera Medical Group Oncology and Hematology, and Dr. Luis Rojas with Avera Medical Group Gynecology and Oncology, Sioux Falls. And with us in the studio is Dr. Debra Johnston with Avera Medical Group Brookings. Thank you, Deb, for joining us.
Absolutely.
And Dr. Huber and Dr. Rojas for joining us. You know, it would have been nice to have you here in the studio. It would have been nice to have you in the studio, but you know, I know what's happened with the snow and the weather, and it's nice to be able to have you at all with Skype. Thank you, and thanks, Deb, for filling in on an emergent basis.
It's fun to be here.
It's great, and we're going to have a good time talking about a not so good time topic, and that is about cancer and how to prevent it. And you know what? We'll talk about prevention of anything, and we'll talk about any aspect of cancer. And between the two of us, we can answer questions about anything. So you know, please call. Well, almost anything. We can try to answer.
We can try.
So please call in your questions this evening to us, 1-888-376-6225. So let's start with our gentleman in Sioux Falls, Dr. Rojas. How long have you been here in South Dakota?
Yeah, thanks for having us, Rick. I've been here for 10 years now, 10 and a half. That's still South Dakota.
I remember when you first came and we had a chance to meet you, and you came up to Brookings and spoke to us about gynecological cancers, and thank you for being part of this. And Dr. Huber, thank you also for joining us. You are my cancer doctor, and I want to tell you personally how much I appreciate your expertise, your wisdom, and your direction.
Well, my pleasure, and thank you for having us on the show, and I'm glad you're doing well, and it's once again nice that we could join you tonight via Skype. It would be nice to be in Brookings now, but we're glad to be here.
Yes. Dr. Rojas, let's start a little bit. You're doing some research right now with regard to sentinel nodes. Could you explain a little bit about that, what's going on there?
Yes, you know, we are trying to minimize the potential side effects that the surgery for endometrial cancer and cervix cancer cause, mainly lymphedema or swelling in the legs. And now that we have good information about, and we identified that first lymph node that drains from the uterus, which is the one that will have the most likelihood of having cancer, instead of taking all the lymph nodes. The studies have shown that if you do that, you have the same oncologic outcomes, and you don't have this significant risk of complications afterwards. Right. So we've been doing that, probably the only center in the region that is doing that, and patients are getting a lot of improvement in the potential complications after those surgeries.
That's that one step further. Every day that you can push forward the scientific research. Mark, you were talking to me earlier about metastatic colon cancer and the approach to people who have spread of the colon cancer to the liver and how we're doing that differently now. Could you explain that a little bit?
Sure, absolutely. I would say 10 years ago or so, if people had spots in the liver, you just gave them chemo and that was it, specifically for colon cancer that spread to the liver. Nowadays, I think we're much more aggressive to try to remove all the spots, fully treat the spots. That's often a combination of chemo, but we often will do radioactive beads to the liver, ablation, surgeries, even if there's multiple sites of disease, gamma knife, which is pinpointed radiation. These are all things we fairly routinely do, for spread colon cancer now that's gone to the liver. And for sure, the 5-year survivals have definitely improved.
Great. So here we have in Sioux Falls a surgeon on your left and an internist and oncologist on your right. And in the studio, we have a family physician, Dr. Deb Johnston. So in your practice, and you've been practicing in Brookings for
20 years or so.
20 years?
I know.
I remember when you were my
I was a
resident.
baby.
When you
I
were
was
a
just a
baby.
baby.
So what is it that you find yourself spending the most time as a family physician doing? And is that anything related to cancer?
Cancer is certainly part of what we do, but most of what I do in regards to cancer has to do with trying to prevent in the first place, getting people to quit smoking, getting people to get their HPV shots, getting people to wear their sunscreen, and then screening, getting people to get their colonoscopies, their mammograms, their pap smears, the lung cancer, or people who are smokers to get their CAT scans for their lungs. Once somebody's been diagnosed with cancer, then I'm looking at my surgeon colleagues and my oncology colleagues to help treat that. That's outside of my area of expertise. All these new developments are so exciting, but it changes so fast that you really need somebody to...
And they go down there and they have these two wonderful experts,
people.
and then they come home and they have problem with diarrhea, or they have a problem with pain, or they have a problem with terminal situation. When do we quit? When do we go forward? You're the person for that.
We're still very much involved as those primary care people because, the person is more than their disease, and they have other health conditions that maybe are taking the back seat to that cancer treatment right now, but we still have to keep their diabetes under control and their heart disease under control and their hypertension under control, and often their depression under control.
You mean they don't have just cancer, they have other things?
Don't have just cancer, they have other things. And the whole family is affected by a cancer diagnosis. So we're frequently having conversations with spouses whose family member has been diagnosed with cancer, and giving them a safe place to talk about how they're doing in that process.
We started this conversation about screening cancer, but we're talking about the complications and the problems with cancer, and we have got the perfect balance. We have a surgeon, an internist, and a family physician, and a lowly
internist.
Media guy now. But what we need is your questions. This is your show. Give us a call, 1-888-376-6225, please. And then let's have some fun with your questions. We can take screening, but we can talk about the complications that are going on, and we can talk about new therapy. We can talk about immunotherapy, which is something that I think we ought to delve into. But I want your questions. I need your questions. Please give us a call. So, Dr. Rojas, your major, probably the busiest, the most common thing that you do in your lifestyle, your medical life, is abdominal surgery, or do you spend a lot of time in the clinic, or what's your life like?
It's balanced half and half between the clinic, because we have to see the patients when they come, and then the other half is doing surgery, trying to take those cancers out before. Most of the cancers that I care for are staged. So we determine how advanced they are by performing surgery and looking at lymph nodes and stuff like that. And that's what guides the therapy afterwards. We're a unique specialty because we do our surgery, we do our chemotherapy for our cancers, even though our friends like Mark, he takes care of them as well. So we work as a team very often, particularly when patients are from another community that I don't do surgery or participate providing care that Mark goes, he takes care of them there. So, yeah.
So it's a whole collaborative process, isn't it? I mean, it's the Brookings doctor, it's the oncologist in Sioux Falls talking with the surgical oncologist in Sioux Falls and putting it all together. One of the things that we promised we'd talk about is screening. And so let's jump right into, we've got a OBGYN a surgeon, and let's talk about breast cancer screening with mammography. There's some discrepancy, isn't there, right now?
Are you going to give the answer to your question?
I might just slip it out. Maybe I'll talk. Let's talk about other kinds of
Let's
screening
talk
first.
about pap smears.
Okay,
because
let's talk about
there's
pap.
something that has changed significantly since the time that I went to medical school. When I was a young woman and went to medical school and was first in practice, it was an annual pap smear. And you started at the age of first sexual activity, and you just kept doing those pap smears every single year. And now,
or was it 18? First sexual activity or 18,
or
whichever
18,
came
whichever
first?
Whichever came first. And we treated an awful lot of women for low-grade, minor abnormalities in their cervixes with freezing procedures or cutting procedures where we'd actually shave off the abnormal part of the cervix. And although when I went through medical school, we had an idea that there was an infectious component to cervical cancer, that was still very preliminary, and we didn't have a lot of knowledge about that, and we didn't have an ability in the clinical setting to test with that routinely. And I imagine that Dr. Rojas is kind of on the leading edge of kind of seeing the change in how we've approached cervical cancer screening and treatment and prevention with that HPV vaccine.
Yeah, now we know that all cervical cancer, right, almost all, is due to a wart virus that is, but it isn't every wart virus.
Correct.
It is just only a certain number of them.
A certain subtypes of that wart virus. The ones that cause the warts on your fingers and your toes aren't the ones that cause the cervical cancers.
Dr. Rojas, your comment about the changes that's happened over your life?
Sure, we get that question very often. Patients are with the idea of yearly pap smear, and the problem is we've learned quite a bit about how this happens and the role of the virus. It typically affects women at the age of sexual debut when they first have intimacy. And we also know that there will likely occur some form of change from that infection that the body, in a period of 1 to 2 years, will take care on its own. So the reason why it has changed is because we have become to realize that we're all this unnecessary, like Dr. Johnston was saying, freezing, surgical procedures, and those procedures have consequences later on. When a woman, for example, at a very young age has 1-2 procedures on the cervix, bone biopsy, or bleed, they may have problems with preterm delivery when they get pregnant later on. And we've learned that the body will get rid of that first contact infection on its own in 90% of. So that's why we don't test so early anymore.
And so the routine has changed, and you're saying now that the routine should be how often?
That's a little bit dependent on age and risk factors, but typically when a woman is under 30, we'll do a pap smear every 3 years, and over 30, it's either a pap smear every 5 years or a pap smear every 3 years, or a combination of a pap smear and testing for that HPV virus every 5 years.
Okay.
And we also know that that HPV virus is something that Dr. Huber has to deal with on a regular basis too, because it is involved in other cancers besides just cervical cancer. It's involved in rectal cancer, oral cancers, laryngeal cancers. So it's not just Dr. Rojas that's going to deal with the consequences of this virus. And it's not just Dr. Rojas that will see patients that are benefiting from that HPV vaccine that I keep talking about.
So, one comment before our next roll, and Dr. Huber, are you a fan of the HPV virus vaccination?
Oh, definitely, beyond a doubt. I think every adolescent, and that's both girls and boys, should get the vaccine, get the series. I mean, I think anything you can do to prevent a cancer, there's no reason not to do it.
And that's what age would you say that those kids should get it?
You can
I
get
believe it's 11 to 12 years old.
Yeah,
That's usually the first.
Certainly more in my wheelhouse. That's the kind of thing that I'm doing. Actually, it's approved down to age 9. And routinely we try to get those kids at 11 to 12, but you can actually get the vaccine up to 26 on label, where insurance should cover it, although
it doesn't always cover it.
Almost always.
Really, it does? Good.
Almost always.
Okay.
And certainly
Medicaid covers it?
Medicaid covers it, absolutely.
So parents wouldn't be burdened with $200 or?
It's not an inexpensive vaccine, but no, most of the time the value is huge, absolutely huge.
Right. So.
And you know what? There's a very important thing to mention. Dr. Huber hit on it. People need to understand this is crucial. I have 3 boys, 2 in the age of vaccination, and they're both vaccinated because they act almost as a vector or dismisser of this virus and do not have a lot of problems. And there's a lot of you can do to prevent this horrible diseases if you get boys and girls. It's safe.
That's right. It's really important to get the boys too, not just because it protects the girls if the boys aren't spreading that virus to them, but the boys have a direct benefit too, because penile cancer is strongly associated with this virus. Again, anal and rectal cancers are strongly associated with this virus, and oral cancers, a lot of them are strongly associated with this virus. So not only does immunizing your boys protect the girls, it protects the boys too, and both of my kids are fully immunized as well.
As our 3 boys and our daughter.
Yeah.
Those are intimate parts of the body, but what, we're doctors, and these are healthcare issues, and so it's important we bring it up.
And what I also always try to remind my parents is that young people don't always get to decide when they're sexually active, and that's particularly true for young women. So
protect them, even if they're not going to be choosing to do.
Even if they're not going to be choosing, because the only thing that would be worse than being sexually assaulted would be getting cancer as a result of having been sexually assaulted.
Wow. Life is full of things that seem to come out of nowhere to interrupt our routine.
I was running with a peer running club that I'm an active member of. That had flooded, so all of the trails were completely flooded. I picked the route that day, and the route took us to the point where I had a grand mal seizure right in front of the hospital. Well, they actually took me by ambulance to the emergency room, where they did a scan and they found a tumor 6 centimeters by 2 centimeters by 1 centimeter. So it was a fairly large. I was 41 at the time, had 2 little kids, 9 and 11. And so then they sent us to Sioux Falls, and Sioux Falls said, this is not something we can do here. Why don't you just keep going on to Mayo? Because they could do interoperable MRIs at Mayo. They didn't have that ability in Sioux Falls at the time. And so we took a couple trips over there to get ready, and then I had a surgeon there that did a craniotomy. During the process, did 2 intraoperative MRIs to make sure they had gotten it all. I then I came home, healed up my brain, and then did 6 weeks of radiation and daily chemo at the same time. And then I came home and did 6 additional rounds of chemotherapy, so 5 days every 28 days, with a chemo drug. And then after that, it reoccurred, and so we started again that 5 days every 28 days, but I was allergic to the chemo. And so I went through this process to be desensitized and then take just the daily dose, and I did that for another year. And that was 4 years ago this November, was my last treatment. It was tolerable on a daily dose, and in fact, we spent a lot of time discussing whether or not I should go off of it, because it just felt like if I went off, it would come back. And so we made the joint decision with my oncologist, Heidi McKean, out of Sioux Falls to just go off. Best decision. No recurrences since. So this July, I'll be a 7-year brain cancer survivor. So there had been times previous to that where I felt a little lightheaded or dizzy, but usually with laying down, it would seem to resolve itself. And there were a couple of runs earlier that year in the heat where I came home and I just felt awful. Because obviously what happens is your brain heats up, it swells, and that puts pressure on everything. Cancer can be the best thing that happens to you or the worst thing. It's kind of what you make it and your attitude that goes along with it. Well, I feel like there are a lot of lessons that you can learn from cancer, how to be compassionate to people, how to talk to people that have cancer, how to help people in their darkest days.
That lovely lady and I sang a duet when at the concert, or at the presentation at the Capitol on pancreatic cancer a few months ago, and she sang also with her son, a beautiful voice. And we thank you so much for your willingness to be under the the gaze of a camera. Tell us about your cancer. That's a real personal thing.
That is very personal.
This is your show. Your questions are key to our show discussion. Call in your questions about cancer to 1-888-376-6225, or send us an email to ask@prairiedoc.org, and we've got questions. And I thank you for questions. A man from Alcester asked the question, how reliable is Cologuard in regard to precancer testing stool samples sent in to see if there's a danger? Cologuard is one form. It used to be Hemocold, but now we're more sensitive. It's more sensitive than Hemocold.
We have a variety of different ways to screen for colon cancer, and kind of the classic, the gold standard, what we in the States recommend as our first choice, far and away, is a colonoscopy. And if any of these other tests are abnormal, you still have to have that colonoscopy, only now you got to pay for it, because now it's diagnostic and
Rather
not
than a
screening.
screening,
So just go get your screening colonoscopy.
There it is.
But
And that's funny why that's the case, but the insurance companies are encouraging screening and not so much encouraging follow-up, isn't that? It's crazy.
It's a whole other topic, but
Cologuard.
Cologuard is another stool-based test. Is that the one that's DNA-based? Dr.
I don't
Huber,
know.
is that one
Dr. Huber?
DNA-based?
It sure is. It's a
Okay.
DNA-based test of the stool that you can do at home. But the issue is it's reasonably good at checking or catching cancers. It's not very good at checking or catching polyps. And really, you want to catch these before they become colon cancers. You want to catch them at the polyp stage. And so, just like Dr. Johnston said, all roads lead back to a colonoscopy. You've got to get the colonoscopy done. If any other tests have more, so just do the colonoscopy and be done with the definitive test. Yeah.
And therapeutic. The other thing about colonoscopy, is that 1 out of 3 in this state who should have the test have had the test, and 2 out of 3 have not. We really, it's one of those deals. You go in, you do the colonoscopy, they're totally out. If there's
But
polyps,
you're breathing for yourself.
and you're breathing
for yourself.
Right,
so
you're not on a breathing machine.
Totally out.
You're snoozing.
But you won't remember it.
Won't remember a thing, and as I've done it, I've watched this thing, and I've had my colonoscopies plenty, and
I've had mine.
And good for you. And so we recommend that, although I do a yearly Hemocold test when I'm doing a rectal exam on guys, because
And that's controversial.
I know it is. I know the rectal exam is controversial, and the Hemocold test is controversial, but that's but I'm an old
But
guy.
you're not letting go of that.
No, I still think a yearly rectal exam, because there are reasons. This is a better test than the PSA, actually, I think. So, but there's controversy about that.
There is
too.
controversy about that.
All right, a man from Parker asks, is alternative medicine and other forms of plant food medicine helpful in preventing or treating cancer? Dr. Huber.
Well, that's a pretty broad question. You know, just to validate that approach, there are certain chemos that really come from natural sources, like paclitaxel from the Pacific yew tree. We know that increasingly diet is important in causing cancer. For instance, high-fat, high-red meat diets. In terms of taking a lot of supplements to actually treat cancer, there's a lot of claims on the internet, but it's hard to know with any certainty if they work. So when I talk to patients, if it's a curative intent situation, I try to discourage taking maybe complementary medicine. On the flip side, if it's really more of a palliative, non-curative approach, I'm much more open to anything they would like.
And I think that as long as the patient doesn't abandon the treatment that we have proved works for the alternative medication, you know, again, for palliative intent, that should be perfectly fine.
And you know, I think this whole thing, people abandoning the treatment when it sounds like it's pretty bad and their chances are poor, and the standard treatment is, you know, we just want to give you comfort. And now you fly to Mexico and somebody gives you
Apricot pits,
apricot pits or whatever it might be for all the money in the world, and you do it because you're going to die, and then they take your money. And so I think you have to be very careful about this kind of a thing. There are a ton of people who will take your money for promise, and I just have to say, locally, we've got wonderful, like Dr. Rojas and Dr. Huber and Dr. Johnston. We've got wonderful doctors here. Talk to them first, and don't do the alternative.
And what I do want to mention is that I'm a huge believer in the importance of diet in keeping you healthy and in supporting you through your cancer treatment. I think that the healthier your diet, the better off you are. And I'm a big believer in plant-based diets too.
Yeah.
I wish I could say I can give up meat. I haven't been able to. But I think there is some pretty good data that a vegetarian diet can be very healthy.
I think that certainly eating a little less food is one of the best advantages.
A little less food in general.
And that's it. A woman from Worthington, about 3 years ago, I was told I had a growth on the pancreas. I didn't change for a while, but now it has grown. It didn't change for a while. Now, what can I do to keep it from growing? I would, that's a tough one. I think you need to have tissue of that lesion on the pancreas. But you know, your doctor should be directing you in that regard, and that's generally before I went to surgery, I had a room full of people consulting to make that decision.
And I don't think there's anything you can do to keep it from growing.
No.
At least there's nothing I'm aware of that somebody can do to keep it from growing. But it's definitely something that needs to be checked out.
Okay. A man from Pierre had a mother that died from pancreatic cancer and wonders if it has a hereditary component. Dr. Huber?
Well, that's a good question. We are recognizing some of the genetic abnormalities that can cause hereditary pancreas cancer. For instance, BRCA2 mutation is associated with breast and ovary cancer, but clearly is associated with pancreas cancer. It may be worthwhile to see a genetic counselor, especially if the family member was young when diagnosed, and they often would look over all the other cancers in the family and can order the relevant genetic testing that may be indicated. I will say that most cases of pancreas cancer just occur out of the blue. There is an association with smoking, but most are not familial, but we are realizing more that there are some familial cases.
Okay. And for you, Dr. Rojas, 2 years ago, a woman had a breast lumpectomy, a lump removed, with some complications. Last mammogram said no growth. Now she has pain on right side and can feel lumps. How will she know if this is cancer or scar tissue?
You know, I don't do breast cancer or breast surgery, but my best recommendation for that patient is go and visit with the surgeon that did your surgery and have it evaluated. I mean, that may lead to other tests to clarify whether are we seeing scar tissue or this another lump, and not, you know, forget to mention the importance of the mammogram if definitely there are concerns lumps within the breast.
Right, there's more tests, there's ultrasounds and so on.
And breast MRI, and there's kind of more advanced and specialized mammography. So, and there's surgeons that have a special interest in breast treatment. There's a high-risk breast cancer clinic down in Sioux Falls, which is not just for breast cancer patients, but for people that are at higher risk, you know, people with the BRCA mutation or people with abnormal breast exams. So it's definitely something that you should stay on top of and go see somebody about it.
A woman from Mitchell is 90 and has some pains. Is there a test to see if there's cancer in any place in the body, even though she's never had it? She wonders why there are pains. And I'll give you my answer on that one. When you're 90, there are oftentimes, even when you're 70 or 60 or 50, there are pains. They have known that if you do screening CAT scans of the whole body, you end up with biopsies that cause, the great story is the guy had liver biopsies and he got infected and bled and needed major surgery and it was benign, and then he had lung biopsies from the same, you know, his total body CAT scan. He was a radiologist and ended up collapsing his lung and needed a chest tube, and it was not cancer either case. And the point is, there's times when you just, unless there's a clear-cut indication of something that would truly improve your life, you don't want to go there. And at 90, now I don't give up on 90-year-olds, but I would say, you know, a good history and physical exam, time with your doctor or clinician, and let that be your best screening test.
Targeted testing. There's a lot of reasons that people hurt. It might be your medicines. Getting rid of some of your medicines may be helpful.
Polymyalgia rheumatica.
Polymyalgia rheumatica, vitamin D deficiency. There's a lot of things that cause hurting. So go visit your doctor.
Very good. A man from Pierre, is there a test to determine why the bone marrow is not producing enough red blood cells? Dr. Hubert, it's your territory.
Sure, the very simple answer is there's a test called the reticulocyte count that checks for the new fresh red cells being cranked out by the bone marrow. However, if there's really a question on the bone marrow, you do a bone marrow biopsy. We often give that with a little sedation. It takes 10 minutes to do it. It takes more time to get it set up, the room's arranged than it does to actually do it. And that is the really the definitive test to give you the answer.
Right.
Question something in the bone.
Everybody is afraid of a bone marrow test, but I've done a million of them. They get done with it and they go, oh, that was all? So every once in a while one hurts. But if I do it right, if I did it right, if I numb it enough and you get it just right, it is not a big deal. And it's definitive.
Particularly easy to say as the person doing it instead of the person having it.
But I've been through a lot of having it
You
lately,
have been
so
through a lot of having it. There's no question about that.
A man from Pierre, is there a test to determine, oh, bone marrow, that's right. A woman from Rapid City asked the docs to explain uterine cancer and endometrial cancer. What's the difference? Dr. Rojas, what's the difference? And then we'll go to the roll-in.
Well, uterine cancer is a general term. We talk about all cancers of the main part of the female organ, the uterus. Endometrial cancer is a cancer of the inner lining of the uterus. So you can have a cancer of the endometrium, so the lining, or you can have a cancer of the muscle, which is a different type of cancer. But the general term uterine cancer just globalizes multiple little regions in that uterus.
Okay. Well, let's, depending upon which cancer you have, there may be a variety of treatments and options for you and your physician to decide among.
Prostate cancer is the most common cancer in men. There's a tendency to try and screen for them. If we catch them earlier, then they're curable. For prostate cancer, there is a blood test called PSA, like I mentioned. It's called prostate-specific antigen. It is a protein that is produced by the cells of the prostate gland. In younger men, you expect them to have smaller prostates, and so the PSAs tend to be lower. In men who, as they get older, the prostate gland grows in size, and so the PSA value will also slowly creep up. But the standard seems to be 4. Anything above 4 is considered abnormal. But recently, the screening criteria has loosened up a little bit because there are a lot of prostate cancers that are very slow growing. The standard treatment options for prostate cancer is starting from the most invasive to the least invasive. It also depends a lot on the grade of the cancer, because not all prostate cancers are the same. If it's a very low grade cancer and a very small amount of cancer, we know that these cancers are very slow growing. And so a lot of times we can even watch them and not do any active treatment. But we call that active surveillance. And what that means is that we keep checking them with their PSA levels, physical exams, and sometimes repeating a biopsy like in a year. As far as active treatment is concerned, there are 2 main ways of treating it. One is by surgery, and the other one is by radiation. The surgery involves removing the whole prostate gland and then joining the bladder to the rest of the urethra. It used to be done traditionally by the open method, and now over the last several years, more and more of these, in the United States at least, are being done using robotic technology. As far as radiation is concerned, there are 2 different ways of giving radiation. One is by giving external beam radiation therapy. That involves radiation given in small doses every day, and typical course consists of 1 treatment every day, Monday through Friday, with a weekend break for about 8.5 to 9 weeks. There's another way of giving radiation that is called prostate brachytherapy, and that involves placing radiation seeds into the prostate. The seeds are like tiny grains of rice that we place into the prostate using special needles and using ultrasound. And nowadays there are more research being done on doing what is called cryotherapy, where you actually freeze the prostate. And nowadays there's research going on to see if you can treat only part of the prostate, not the whole prostate. And so there are more experimental studies being done in that regard right now.
We thank Dr. Bhatt for that information, and the little clip of actual surgery is kind of thrilling. We've got a lot of good questions, and we're going to run through them quickly. Quick answers. Facebook viewer has an aunt in her late 50s and was diagnosed with breast cancer a few years ago. After some tests, they said she had 2 different types of cancer. She recently quit smoking, smoked since she was a teenage person. Could smoking have contributed to breast cancer and 2 different types of cancer? And I'm going to ask Dr. Rojas.
Well, I could probably jump in on that.
Oh, I'll let Mark jump in on that.
Yeah, smoking is probably less associated with breast cancer than much more of the typical smoking-related cancers like lung or bladder cancer, some of the others. It's hard to know about the 2 different cancer types without knowing the specific. Sometimes there's a pre-invasive and an invasive breast cancer. I guess it would be just knowing the details. There's 101 reasons not to smoke, especially when it comes to cancer. Beat myself up over could there be a risk with breast cancer. The key is just to put that behind you
and go forward. Speaking of smoking, smokers who have had more than 30 years of smoking a pack a day, or 15 years of 2 packs a day, that kind of a thing. People are talking about low dose CAT scans for
high resolution CAT scans as a screening test to try to find those cancers when they're really small and really early and really treatable.
So we should start at what age?
50, if I recall correctly. Is that, Dr. Huber, does that sound correct to you?
I think it was 55 on the lung screening trial.
And that's the U.S. Preventive Services,
Services
and
Task Force.
they're a group of conservative.
They're
don't
very
wanna test.
conservative.
So they say once a year for smokers with
Yep.
30-pack year
Yep.
history.
Until you've not been a smoker for 15 years. So if you quit
Oh.
15 years ago, you don't need that screening. But until that point, they recommend that screening.
And if you've ever smoked, they're recommending it in a male at 60 to have an ultrasound of your abdominal aorta. Which is not screening for cancer, but it's screening for abdominal aneurysms.
Aneurysms.
So
That's
do
right.
you go with that idea? I recommend, those ultrasound people that travel around the state, I think most of it is not appropriate, but I think the abdominal ultrasound screen for men who've smoked or people
And
who have smoked
It's
is
important to remember that with the Affordable Care Act, anything that's recommended by the U.S. Preventative Services Task Force with a high-grade recommendation is supposed to be covered by your insurance.
and if
So
it isn't,
that-
shout.
I mean, there are exceptions. Insurance companies have managed to make exceptions for themselves, but that lung cancer screening, that abdominal aortic aneurysm screening, your pap smears, your mammograms, your colonoscopies, those are supposed to be covered. So.
Okay. Quickly now, we've got a bunch of questions.
Okay, all right.
A woman from Edgerton would like to know about metaplastic cancer. Is there any new news about metaplastic cancer? Mark Huber, you're up.
We see that in breast cancer. It's a rare subtype of breast cancer. It's known to be relatively more aggressive. So that's definitely something you'd want to have treated at a bigger center. For instance, at McKinnon in Sioux Falls, we have a weekly tumor board that discusses some of these complex cases.
Okay.
So fortunately not very common, but really you should go to a specialty center when found.
It's a tougher diagnosis. Dr. Rojas, a woman from Aberdeen asked the doc's opinion on ovarian cancer and if there's a blood test known as a 126.
So yes, there's a blood test that we use called a CA-125 that really should not be used for screening because it's very nonspecific. I mean, you may have a cold, flu, and it may be off. But that test helps us if a patient has a pelvic mass and we go to the OR to remove it thinking it may be cancer. If the CA-125 is elevated and she has a cancer, then we can use that test to follow progress of the patient and how she does after the cancer treatment. But that test should not really be used to try to pick up cancer because you may, again, cause a lot of harm with necessary testing.
And you may be artificially reassured that there's not a problem
When there is.
when there is a problem. So it's not a good screening test, bottom line.
And is Avera doing some research on gynecological cancers right now, Dr. Rojas?
Yeah, we have a couple of research on, the treatment side, and specifically, we have our own internal clinical studies that have been designed by some of our pharmacists in combination with a team of doctors. Testing new drugs and new drug combinations. In fact, we have 2 trials that are unique in the nation with drugs that we have combined. And seeing good results, tolerability of those patients. We have other trials coming up, testing other potential markers, screening other tests can be done to pick up the cancer.
Okay. And then I was going to ask you, Dr. Huber, we talked about immunotherapy as new things. People are hearing a lot of things about immunotherapy. What would be a take-home message that people would like to have? I mean, we're going to need to get back to questions, but quickly, take-home about immunotherapy or different kinds of cancer.
Well, I'd say, Rick, that it's really revolutionized many different tumor-type treatments over the last 5 to 8 years. It's hard to keep up on all the FDA approvals that are coming out. I will say that it's very well tolerated. Side effects are much less and much more manageable than chemotherapy. And in about 8 or 10 tumor types where it's approved, it's often the preferred treatment. Jimmy Carter is 95 years old and being treated for melanoma with chemotherapy. You would not give a 95-year-old regular chemo. So I think that speaks to how well it works.
And the beauty of it, Mark, is that you're not really treating cancer. You're unleashing the potentials of your own immune system to fight the cancer for you. So that's very, very important.
Right, it like magnifies the immune system in your own body to fight. That's exactly it.
Thank you on that. We have a Watertown woman about bladder cancer, other options besides chemotherapy, also if robotic surgery is an option. So, but there's a lot about bladder cancer depending upon how much it's spread.
How invasive.
How invasive it is. And well, a lot of it, they'll surgically remove the tumors that are within the bladder, and then they'll flush the bladder with chemotherapy. And remarkable results with that. So, but you got to depend on your personal doctor on that. And sometimes it spreads, and you have to talk about chemo. Anything else that either one of you, any of you, would like to say about that? Quickly, we'll move forward then.
Any blood in the urine needs to be checked out. That's my take-home message on bladder
so
cancer.
the lesson, it might be a little late for her, but if you see blood in your urine, go to the doctor.
Get it checked out.
And if advanced immune therapy works very well in bladder cancer, there's actually 5 of the immune therapy drugs approved in bladder cancer. So it's there's been some changes for the better.
Mm-hmm. We have a bunch of questions that need to be answered that we won't get to at this time, and so you go to Facebook and look up Prairie Doc, and then we'll right now after the show we'll go to finish the questions if we don't get what we don't get to. Father died of colon cancer in 1984. Since then, caller has a colonoscopy every 5 years. He's 79 now. Should she continue getting them every 5 years?
You know, the short answer would be no, but the more nuanced answer would be it depends on her state of health.
Yes.
If she is a very healthy, vigorous person where I'm not expecting that she's going to die from something else in the next 5 to 10 years, then I would continue doing it.
I would.
On the other hand, if she has a bad heart and bad lungs and uncontrolled diabetes, it's time to stop.
Right. What's the newest treatment used for pancreatic ductal cancer, Dr. Huber? We're out of time. And now for the winner of tonight's Prairie Doc quiz question, true or false? The American College of OBGYN recommends yearly mammograms beginning at 40. However, the American Academy of Family Physicians recommend that annual mammograms start at 50. Is that true or false? Deb?
True. And other organizations recommend every 2 years. So there's a lot of different recommendations.
It does exist. In fact, for women age 40 and above with the average risk for cancer, the American College of OBGYN and the American College of Radiology recommend yearly mammograms at 40. But the AAFP, the ACP, the internist group, the U.S. Preventive Task Force recommends 40 to 49. Inform the patient, you choose, but yearly mammograms begin at 50 for sure. It was Norman Kuhlman from Pipestone who answered the question correctly. Norman, thank you for participating, and a book will be in the mail to you soon. We'll be right back after this.
In a world where selfies are seemingly innocent, something lurks. And no one is spared.
How goes it?
It's flu season.
Screening for cancer is like fishing for walleye. If you have the resources, you can buy a good fish finder to see where the fish might be. When the finder indicates that there are fish down below your boat or your ice house, you know that there might be walleye, but they also could be carp, northern, or weeds, and not walleye. If you decide to drop your hook, sometimes you catch a big one. Okay, this is not a perfect metaphor, but screening for cancer often requires advanced and expensive technology, which is not always accurate. Sometimes you find nothing, and sometimes you find a dangerous cancer that can be treated. Screening for cancer is when there are no symptoms. This is different than when cancer is discovered because of symptoms, like when Lung cancer induces coughing with bloody sputum, or colon cancer causes blood in the stool, for example. Examples of screening would include yearly low-dose CT scans of the lung in 55 to 85-year-olds who have smoked a pack for 30 or more years, or colonoscopy every 10 years in people 50 or older. Experts measure the value of screening in several ways. First, what are the costs of the test and the costs of any further treatment that might follow? Costs should mean the financial costs to patients, to insurance companies, or to the government. But measuring costs should also include the pain and emotional suffering to patients that may result from testing. The second way to measure value for screening comes from measuring how sensitive the test may be. If it isn't sensitive enough, then it will miss cancers. If it is too sensitive, then it will indicate cancer even when there is no cancer or no danger from harm by tumor or cancer. A third issue is the age and well-being of the patient being tested. If the individual is very elderly or ill, screening may be inappropriate. The point is that while screening can be life-saving, it is not always a good idea. So after doing your own research on the topic, when asking your physician or care provider about a screening test, realize the complexity of this issue. And please depend on the wisdom and experience of your care provider. These are complicated waters, and we all could use a good fishing guide. I thought that was pretty good, a good fishing guide.
I know where your mind is.
Yeah. A big thank you to our guests, Dr. Mark Huber and Dr. Luis Rojas, for joining us via Skype from Sioux Falls, and Dr. Deb Johnston for volunteering to come in tonight to our studios at South Dakota State University Yeager Media Center in Brookings. We sincerely appreciate everyone's efforts tonight. Your experience and insights make this show possible. Thank you. In South Dakota, as in the United States, we're experiencing a widespread influenza activity resulting in 15 deaths and 320 hospitalizations in South Dakota. The majority of flu illness has been among those 50 of age or older. Influenza vaccine is the primary way. The vaccine is the primary way to interrupt this flu activity, while not 100% effective at preventing illness. Flu vaccine lowers your risk of being hospitalized with flu complications and dying from influenza. We still haven't seen the influenza peak in South Dakota, and there's still plenty of benefit of getting your flu shot today or tomorrow. Getting your flu shot now will still offer some protection in the next few months. Well, that does it for tonight. From all of us here at On Call with the Prairie Doc, until next time, stay healthy out there, people, and go to Facebook, catch it after hours.
Music has charms to soothe a savage beast, but it also may be able to heal. The health benefits of music. Next time on Call with the Prairie Doc.
Major funding for On Call with the Prairie Doc has been provided by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call Television as it continues to open doors for important medical information.
And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota.
And with the ongoing support of these individuals and institutions.
Brookings Health System,
Ophthalmology Limited,
American Academy of Family Physicians Foundation and South Dakota Academy of Family Physicians,
Avera Heart Hospital,
Dakota Allergy and Asthma,
CoBank,
Fishback Financial Corporation,
Vance Thompson Vision,
Aberdeen District Medical Society,
Black Hills Medical Society,
3rd District Medical Society, Brookings, Madison, and Flandreau,
Dakota Bank,
Orthopedic Institute,
Physicians Care Sanford Clinic Community Service Committee,
and Swiftel Communications.